Brilliant. Welcome. So we've got people joining us. So we've got Dennis joining us from Washington, DC, which is great. And we've got people from all over the UK as well. So welcome this evening. So just to remind you, with questions in the chat, we're going to be recorded and we've just started the recording now. At the end, there'll be time for some questions as well. And I'm going to hand over to Danny to introduce our guest speaker. Thank you, everybody.
Thanks, Libby. So I am absolutely delighted to introduce Dr. Shrouk Messahel, who is a PEM consultant in Alderhay in Liverpool and a longtime friend of mine as well. Shrouk is the vice chair of PERUKI, which is the Paediatric Emergency Research in the UK and Ireland network, and says herself that coming from a clinical rather than an academic background, she is basically the embodiment of how you can get real research excellence without that PhD. So I'm going to pass over to Shrouk. He's going to be talking to us about PEM and PERUKI, the journey so far.
Thank you so much, everybody. Welcome, everybody. Thank you for joining us this evening and spending this time in your precious evenings with us. I'm going to try and share my screen. I always have to do things in a slightly structured way. Thank you for that introduction, Danny, as well. So I'm going to see if I do this right. You can see my screen, everybody? And is it on slideshow or can you see the whole?
We can see the whole thing at the minute, Shrouk.
If I click on slideshow, does that?
Perfect. That's looking great.
Great. Okay, so PERUKI is the Paediatric Emergency Research Network of the UK and Ireland, and it's much more established than it was previously, and I'm hoping that all of you know about it, heard about it, something like that. And I just want to take you on a little bit of a journey of where PERUKI started, how it's grown, how I've grown, I think, as a clinician, as a researcher, and what studies are happening at the moment within the PERUKI network, with a particular focus on one study, and then what the future might hold for PEM and research. So this was the inaugural meeting of PERUKI more than 10 years ago. We met in Birmingham. It was the brainchild of Mark Little, and there's some faces that you can see, the giants of pediatrics and pediatric emergency medicine in there, and some fresh faces. That's me, looking very thin. I didn't quite realize that there was going to be a formal picture, and I'm not entirely sure I would have worn my Gap hoodie if it was going to be recycled forevermore. But the UK was a little bit late to the party. There was some fantastic pediatric emergency research networks that were really producing some really top quality research around the world. The UK and Australia Research Network, the North American Research Network, and we felt a little bit late to the party when we actually kind of came to do this. So it was a let's get this up and going, let's get this as done in a way that would enable us to conduct research in our growing specialty, and let us, the clinicians of our specialty, be advocates for it. And this is how it was set up. So an individual could join PERUKI and say, I'm a member of PERUKI, and an institution, so an organization, could join PERUKI, and it's free. So it's free for the organization, it's free for the individual. And we try to ensure that in the current state and of the NHS, that wasn't a requirement to be able to engage in research. No payments were necessary. Some research networks require a nominal payment, particularly from an institution. We were quite adamant that wasn't that was a barrier to engagement in research, particularly if you want to get something off the ground. The actual executive committee, we have a chair, we have a past chair, we have a vice chair, and in recent times we've expanded regional representation. We have a secretary, we have trainee representatives and a nurse representative now. And then the research steering committee. So this is really, really important for a functioning network, is to utilize everybody from institutions, and have an institution with a site lead, and that person is offered to give peer review to studies that are coming in. And that is really, really important. We found that's really important for applications to funding bodies to say, actually, PEM consultants, PEM nurses, PEM people who are actually working on the ground in this specialty think this protocol, think this research idea is really, really important, and they've critiqued it, and we've we've listened to the critique, and we want to put this proposal forward. And then we have general and general executive meetings, and we have public meetings as well, which again have changed slightly, just to in terms of cost, just to reflect the growing kind of, you know, expense of booking places and things like that. So, but the last one that we had was in Cardiff, and it was attended by over 100 people. It was fantastic. This is the executive committee from the last PERUKI meeting, which is in October 2024 in the Cardiff Stadium. I forget what it's called. I'm not sporty. I apologise to all the sports fans out there. It was a very impressive stadium, I have to say. As the Twickenham something rugby. Apologies. But this was a fantastic setting for it, and we have a great future hopefully ahead of us. The Research Steering Committee is part of our are the centres across the UK that see children. So you know, there's over 70 sites. We across all the nations of the United Kingdom and Ireland. We have a specific Irish representative and we are looking to ensure that everybody from these sites has an opportunity to participate in research, because these sites represent over 1.2 million patients, paediatric patients, and rising. So we're always getting new sites on. So you can imagine a network being able to access over 1.2 million paediatric patients. It's quite a powerful thing. Now, when I got into PERUKI, it was as a member many years ago. I was involved in the ECLIPSE study as a trainee, and then subsequently as a consultant. And this was one of the quotes from one of the feedbacks from the meeting, which was, you know, I wasn't entirely sure research was for me, but I saw that other people in PERUKI were kind of not as clever, you know, they were the same as I am, and if others were doing it, then I could do it too. And I think that's the difference between a network which has grown up from the ground than a network which is kind of university based or institution based and is kind of like imposed on the masses. And at the time, 10 years ago, we put together, so Stuart Hartshorne, who was the PERUKI secretary at the time, led a piece of work which looked at the top 10 research priorities. So we all had a little think, and we all kind of put our questions in, and there was a Delphi process that happened, and we had our top 10, and that was published. So at least there was some guidance within, and this was UK clinicians who in paediatric emergency medicine who wanted to research these priorities. So that was quite important, because Australia and New Zealand were doing something else, the North America were doing something else, Europe was doing something else. It was very important that we had ownership of what we wanted to research, and that these questions were important to us. And this is what, you know, 10 years ago, this is what we were thinking at the time. And this piece of work has been recreated this year, so 10 years later. Charlotte Sloan led that piece of work for her PhD. And if you kind of look at these questions, they're, you know, they're not really. I think somebody was talking earlier about, you know, lab-based biomarkers, creating something out of scratch and things like that. It's actually just really basic questions which encapsulate the difficulties that we have as paediatric emergency clinicians on the shop floor, our day-to-day questions on the shop floor. Do guidelines for C-spine injuries work in children? You know, it was what are we supposed to be doing in this particular condition for children? And it was really interesting. If you kind of go through these studies, these questions, you say, well, actually, we have done some work in biomarkers for predicting serious illness in children with fever. We have done some work with major trauma centres. The EVITA study, number 4, the EVITA study is coming out about IV medication for severe asthma in children. So the PICBONE study, question number 7, the PICBONE study is going to hopefully answer that. Number 8, that was the particular in children. The PIC study looked at that. So there has been work that has been done because this list has been generated. So what I'd like to talk about now is getting involved in research, how to get involved in research, how I got involved in research, the current PERUKI studies with particular focus on one study, which was the Crescent study, because I think that encapsulates a lot about paediatric emergency medicine and a lot about research in paediatric emergency medicine, and then talk a little bit about the future of PEM and research and things like that. And hopefully I'll stick to time. So this, I might be teaching you all how to suck eggs really in this, and I apologize, but it's really basic. It's how I started was, I didn't even, I was a clinician through and through. And when I found out about the ECLIPSE study and being involved in the ECLIPSE study, I was approached as how do we run this study in emergency departments? And I said, well, what are we running the study for? We've got the APLS guidelines. It says to do this, this, and this. This is the order of medication. And they said, yeah, but there's no evidence for that. And the last time phenytoin was trialed was in dogs in the 1950s. And I, it just kind of slightly blew my mind. I was a registrar at the time who was very focused on making sure that my clinical skills were top notch, and I was getting the diagnoses right, and I was kind of treating adequately. But what I didn't realize that I was following guidelines completely blindly and not questioning those things. And so there was an opportunity, kind of wool came off eyes type of situation, and there was an opportunity to learn a bit more about research, because in the UK there's 2 very separate paths. One is an academic pathway to go on, and one is a clinical pathway to go on, and never the 2 shall cross. So it's really quite challenging to get research experience while you're doing a clinical job. And there was an opportunity for me to do our local NIHR, which is all changed now, but our local NIHR regional branch had 4 new consultants had said, oh, come and learn about some research, we'll pay you 1 day a week. And I said, that's great. The night before the interview, I was practicing with a colleague, and I couldn't even say NIHR properly in those lines. It was I kept on trying to say NHS or NHR or NH something, and when I thankfully got that and passed the interview, I didn't actually have to say NIHR in the interview, which was great. My colleague wrote this card for me. So if I can be engaged in research when I didn't even know how to say the NIHR properly, then you can all do it. And it was I found myself a little bit isolated. I found that in a busy emergency department, I was quite isolated in trying to engage clinicians, engage nurses, engage staff, engage anybody in research. And the 4th study was a study looking at buccal fractures, so torus fractures in the distal radius of children, very, very common, very minor injury. Like I said, PEM research doesn't have to be kind of, these amazing questions. It could just be real focus on what we see really quite commonly. What is the best way to treat it? No immobilization at all, so kind of just observation, analgesia, or a splint, a removable splint of some kind. And there was I made lots of cake, and what I found was cake, and when a patient would come in, and it would be, oh great, kind of recruit to the study, and there's 50 other patients waiting to be seen, and the nurse in charge starts screaming, ah, and the cake gets kind of, oh, here you go, have some cake, kind of, in the mouth instead, was really quite challenging. And one of the senior nurses, I remember, in our department had said to me in front of other nurses, and what's the point in engaging in research? And that was a real big culture change. And some departments had a better culture, and some departments didn't. Some departments didn't even have anybody who was engaged in research and needed kind of to find friends outside to be able to engage with people within their department. And so from being a co-applicant on a research project to being a research scholar, to then looking for other opportunities of how do I learn a bit more about research? How do I peel back the layers of what this whole organization is, and how do they come up with the questions, and how do they fund them, and how do I come up with questions, and how do I apply? So certainly engaged with PERUKI and the NIHR, the trauma and emergency care groups, to try and understand how do we strategically engage people in PEM research. How do we do that in EDs? And that's a real challenge for any pediatric emergency medicine studies, because there'll be always good questions, there'll be always somebody who's enthusiastic, but how do you actually engage a whole entire department to be able to deliver research goals? It's been a change recently in the UK. So CQC now inspecting bodies, CQC now have research as one of the requirements that emergency departments have to engage with, and it's a subtle but an important difference that in the GMC guidelines it separates research and teaching. So in domain 1, it always used to put research and teaching together. Oh, you have to be good at research and teaching. Research and teaching is kind of together. So people just used to pick one, or just kind of like ignore the research part, but just engage in the teaching part. But now it's actually a separate line. So those types of changes really help to engage people in saying, well, actually, no, we have to be responsible in saying what we have done individually, but also as a department and as a trust in engaging in research in pediatric emergency medicine. And then there was opportunities to get on HTA panels. So on HTA panels, they're always looking for people to review PCOs, to generate ideas, to review funding calls, to review funded work, to review protocols. There's always this churning of needing people to do this type of work, and it's kind of like an application form that you apply. And that was a real look behind the kind of, you know, peek behind the curtains. How on earth does this organization work? And then I got the opportunity to write my own grant, which was it was so much more difficult than I thought it would be, because the language was something that I needed to learn, and I needed to know what funders liked and what PPI work was needed, and who in the team I would need to be able to deliver a research a study. So there's been lots and lots of learning, and I've been a consultant 10 years now, and it's kind of it's gotten to the stage where I'm quite comfortable now, but it's been a real learning process for me, and it's certainly added a lot of value to the work that I do. And I bring that back to the department. So it's all like a web. So, you know, you have our emergency departments, and my emergency department is Alder Hey up in Liverpool, but I've got a research team around which I advocate for. We're linked with PERUKI, and we're linked with the NIHR, and so there's just lots of kind of integration of organizations on the ground in our emergency department to be able to deliver research competently to patients who come in. And I almost feel it's their right. It's their right to be offered research and to be engaged in research in these situations. And that's the only way that we can advance our specialty. I can't think of anything worse than ending my career exactly the same way as I started, and, you know, with no progress and no kind of questions being asked, and no betterment of outcomes for patients through asking questions and getting those answers. So really, really basic is do your GCP. It's a free course. You've got to get on the NIHR Learn. You've got to get on NIHR website, and you have to register for an account, and you do your GCP, and that's the first rung of the ladder of being involved in research. A lot of studies, even if you're just on the delegation log, or want to identify patients, or just have a better understanding of the studies that are going on in your trust, it needs your GCP to do. It takes a few hours to do. It's not erroneous at all. And then once you have that, find out what's happening locally in your trust, get on the delegation logs, have a little look at the training logs, become an associate PI if you're a trainee. That's a great way of understanding what goes on to become a principal investigator of a study. Attend research meetings, so PERUKI meetings, and local research meetings. There's oh my goodness, I forget the name now. Wessex, down in Wessex, they have a great the Premier. Is it called the Premier down in Wessex? Yeah, they've got a great research meetings that happen very regularly down there, all on Teams or Zoom, or all online. And then, if necessary, speak to the local R&D or the CTU, or the PERUKI site lead, or even just any member of the PERUKI exec. And we all started from somewhere, so and we are very we're very understanding of starting from the ground up, because that's where we've come from. That's where I've come from. There's lots and lots of free courses on the NIHR website. We kind of contemplated this in PERUKI, and kind of said, well, should we recreate something specific to PEM, or specific to the PEM interested folk, as to how to get engaged in research, or what's the way to do it. The NIHR do this so well, and there's really no point in recreating the wheel in that kind of sense. And the NIHR fund an amazing array of opportunities, particularly for trainees or nurses or allied healthcare professionals, to engage in research. It is a competitive process, but there's opportunity after opportunity after opportunity, and if you miss this round, there's a next round, and it's never ending. It's really good. They're very proactive in doing this. Okay, so I'm going to move on to talk about a few current studies. Currently, so if there are any questions, then happy to kind of interrupt about any of that. These are the studies in PERUKI at the moment, and you might recognize them, you might not. Some are literally brand new, not recruiting yet, but hopefully we'll recruit a little bit later, and some are really quite established and are on their third iteration. So BronchStart, I think BronchStart has been a phenomenal example of utilising the PERUKI network and understanding how busy clinicians are, and looking at a very, very common aspect of clinical paediatrics, and asking very simple questions and producing a phenomenal piece of work. So BronchStart 1, I don't think it was called BronchStart 1. I think it was just called BronchStart then. But it was just an observational study. What does RSV bronchiolitis look like in the UK post-COVID? And they had a really innovative way of inputting data. So it was a QR code that any clinician would be able to scan, input the clinical details. They were anonymized, completely anonymized clinical details. And once that data was inputted, they had programs behind the scenes which would pull the data locally and pull the data nationally in real time. It was a great piece of work. You could see the wave that winter in real time. And then there was a BronchStart 2, which looked at kind of like, the microbiology behind it and the admission behind it. And then there's the current, those two studies were referenced in the JCVI statement put out when they decided to vaccinate for, not really a vaccine, but vaccinate for RSV in this country. So the impact of these studies, which is a clinician on the shop floor scanning a QR code and entering 2 minutes of detail, have actually really changed the UK landscape several years later. And the third iteration of BronchStart at the moment is looking at how many patients come in who have RSV positive, whose mothers have received the vaccine. So kind of like, you know, effectiveness of the vaccine. So again, all online. We need consent from the mother to be able to access her records online. Because all of this information is online now using the NHS data, and that will be able to, you know, provide some real good quality data and be able to answer, you know, how effective is this vaccine in what we're seeing in wintertime. The CRAFT study has closed to recruitment, but it's still ongoing in follow-up. And it's kind of a joint orthopedic ED study, and that was looking at completely off-ended distal radius and ulnar fractures. And I'd encourage you to go onto the CRAFT website and look at the before and after pictures of remodeling in children in the distal radius and ulnar, and they're now just in the follow-up phases. So in 3 years' time, we'll hopefully be able to have the answers to whether these children need to go to theatre, or whether we can just straighten them out slightly, put a cast on them, and they'll remodel successfully. You know, that kind of change of practice would be absolutely amazing, because that's something that we would be able to do in the emergency department, potentially with the orthopedic colleagues, and those patients wouldn't necessarily have to be admitted, and etc. etc. The ODSOC study is another orthopedic study. So Dan Perry, Professor Dan Perry, is the paediatric orthopedic surgeon who is revolutionizing paediatric orthopedic and trauma studies. The ODSOC study is looking at Salter-Harris 2 fractures of the tibia at the ankle joint, and similar to CRAFT. Can displaced ones be just casted and left, or do they all need to be reduced, and what are the outcomes? So that's had a bit of a shaky start in terms of recruitment, but we have used a lot of what we have learnt about delivering successful studies, and the recruitment has picked up. The Curly study is looking at UTIs in children presenting to emergency departments, is looking at simple UTIs, simple uncomplicated UTIs, and what is the length of cephalexin which is needed to result in microbiological but also in symptomatic cure. Had a bit of a shaky start, wasn't recruiting as well as we thought it would recruit, and we've expanded sites. So we've used the network to engage in which sites would want to recruit for this study, which additional sites would want to recruit for this study, using our local knowledge of sites and speaking to sites to be able to say, you know, do you think you'd be able to deliver this to deliver this study as well? And there's recently been an amendment change based on feedback from people who are engaging in the study and saying, actually, we'd really like it if we could recruit these patients, or the inclusion criteria is too restrictive. Can it be changed? And the study team have taken that on board and have put an amendment in, which is now live, to increase the inclusion criteria, and that recruitment has certainly picked up. So again, it's a communication. It's using the network as a communication, and to say, this is what we're seeing on the shop floor. We're missing all these patients. We're not going to get the answer to this. You know, potentially the study would have to close, but listen to the people who are recruiting these patients on the shop floor, and an amendment was successfully done. The EASY study is looking at small babies, small low-risk babies, again for UTIs, and the need for IVs, or can they be converted to oral straight away? This again had a few issues in terms of recruitment, and this kind of needs paediatric emergency medicine and general paediatricians to kind of like but both be on board and sing from the same hymn sheet in recruiting, but that is still ongoing. The EVITA study is the IV asthma medication study in severe, moderate to severe asthma. That is coming to an ED, hopefully near you, relatively soon. That is a way of successfully asking the question, and you know, as a network, asking the question, and then having it funded several years later. And this is a study which has paediatric emergency medicine clinicians in it, general paediatricians in it, and respiratory paediatricians in it. Do you imagine the meetings? But they are really, but this is, you know, we're all very engaged to be able to try and to answer this study. So that's kind of, you know, so we've talked about a range of studies so far. We've talked about online observational studies, drug studies in relatively well children, to orthopedic studies, to IV treatment in quite sick children. The HELP study is looking at looking at parental engagement in online information. So how do parents engage with looking at videos which describe common clinical conditions, diarrhea and vomiting, your child has had a head injury, etc., etc., and getting feedback for that, because information for parents and carers is really important, and ensuring that they seek help appropriately is also important. So that's still ongoing. That's Sarah Fissler's study. BAC B is looking at bronchiolitis again, but that's looking at moderate to severe bronchiolitis and looking at what type of respiratory support is most useful. Is it Airvo? Is it CPAP? And that is in certain centres in around the UK. Not all centres are engaged in this because of the provision of CPAP or Airvo within emergency departments. And then the FROG study, that is looking at methods of urine collection in children. So what's the best way to collect urine from children? Is it an SPA? Is it a bag? Is it a cotton wool swab? Is it a clean catch? So just really, really kind of, you know, we've got such a range of studies that are happening in emergency departments, because we see such a range, and no question is basic, you know, enough, and no question is hard enough. So if there's no questions about those, I'm sure I've missed some studies, but those are the main ones that come to mind. Before we move on to talk about the crescent study, is there anything that I need to answer? Everyone happy?
I think we're all happy. If you've got a minute, I'd love to hear a bit more about the FROG study, because I think urine collection is something that is just a massive headache in PTD and takes up so much of our time. If you could tell us a bit more about it, because we're not running that one at my place, so I'd love to hear a little bit more about that.
Okay, so the FROG study is Tom Waterford in Belfast, and he's looking at, he often jokes, I'm not saying anything out of turn, he jokes about himself as being the urine man. So that's a nickname that he's generated for himself. He's this is a pilot to start off with, to say to look at is this a doable study? Can people engage in this? There's a lot of PPI work that is going on in the background to be able to inform the best way to get urine, but urine that is you know, kind of worth it. You know, you're worth the wait. It's not going to be contaminated sample, you know, forever. The caveat to this study is that for departments to be able to engage in this study, they have to engage in all means of urine collection. So if you're a department which doesn't do SPAs anymore, then you can't really kind of engage in it. And it's not only interviewing parents, but it's also interviewing clinicians as well. There's a lot of qualitative work that is going on behind the scenes. You know, what was difficult, what about this, and a lot of patient information to be gathered from this study. So a small step in hopefully answering a question of how should we be collecting urine off children when they come to emergency departments, particularly those who are still in nappies.
Thank you.
So
I feel like
yeah.
SPA is a dying art in paediatrics, I think.
Yeah, if you go on the PERUKI website, there is a page on the PERUKI website which talks about current studies, and Tom has done a great little summary and a little recorded message about this. So have a little look at that. If you're interested as a site, then please contact Tom, the urine man, directly. Okay, so the Crescent study, I feel, encapsulates a lot of what we do quite well and how we've adapted in PEM to enable research in a network. And the Crescent study is carbogen for status epilepticus in children, and it is the chief investigator is Rob Forsyth, and it builds on the Eclipse study. The Eclipse study, if you remember, was levetiracetam versus phenytoin in status epilepticus in children. So it was looking at that stage 2 part of the APLS algorithm. There were equivalent studies in Australia and New Zealand, and in North America, although the North America one had valproate as a third arm. And that QR code takes you to the Eclipse paper. And we learned an awful lot about how to deliver research in emergency departments in really challenging situations from Eclipse. And we used a lot of that to inform how Crescent would be delivered. So the things which were challenging in Eclipse were, how on earth do you get people to be on board to research patients in emergencies? How do you do research without prior consent or deferred consent? How do you screen adequately? So how do we ensure that we've got adequate screening and people are still keeping an eye on the board in emergency departments when it's really, really busy? And then kind of reporting results and enabling the results to be incorporated into something which is meaningful for us in emergency departments, and not just have that research just kind of sat there in a paper, kind of locked away and never to be acted on. So that all of that kind of pathway was really quite interesting. And so Crescent is the next iteration of it, and that is looking at inhaled gas in children. I'll just move on, actually. I'll just talk about the gas itself. So carbogen is the gas. It was originally known as Meduna's mixture, and Meduna was a neuropsychologist, I think, in the turn of the century, early part of the 19th century, who used this for all kinds of treatments of neuropsychoses and epilepsy and things like that. And I think he used a mixture of 50% carbon dioxide and 50% oxygen. So this kind of iteration of carbogen has been around for a long, long time. And it works on the principle that that manipulations of brain pH can affect what happens to that person. There have been studies which show that the brain is compartmentalized, so there is a difference in pH between different compartments of the brain, and if we can use that to our favor in clinical practice, then is that worthwhile? Because the human body doesn't compartmentalize things without a reason. These kind of don't just happen kind of by chance. There's a reason for it, and we don't quite understand how. So normal room air is 21% oxygen and 79% kind of nitrogen. Exhaled air has 5% carbon dioxide in that. That's what we breathe out. And the study medication is either looking at 100% oxygen or carbogen of 5% carbon dioxide. And it's can this manipulate the brain pH enough that it actually stops seizures? You think, how on earth, well, how did this come about? Well, in 2011, there was some studies done in animals, in rats. And they gave rats who were fitting carbogen at 5%, and within 5 minutes these rats stopped fitting. And so it was thought that actually, okay, all right, well, if it happens in rats, can it happen in humans? And so this is the Crescent study is actually it's a phase 3 study, so it's earlier on than the usual studies that we are used to, the usual investigative medicinal products that we're used to dealing with in emergency departments. So this is, it's not complete kind of, you know, pick a drug, let's just test it on children. It's not that at all. There is evidence behind it, but we need to actually kind of put that into practice and see if this is worthwhile doing and if there's evidence behind it. And again, Schumann looked at adult patients, and they had febrile seizure onset to hospital admission, and they found that the capillary pH was lower in patients who had shorter seizures. And the current participating sites are there's about 12 sites. I think a few more sites have joined up since the original sites, because recruitment was a little bit challenging. And recruitment was challenging because we didn't quite anticipate the landscape had changed. So this was earlier on in the algorithm. So Crescent was earlier on. So the figures for Crescent were taken from Eclipse. And we thought, okay, well, this is the number that Eclipse saw, so Crescent will probably be able to see this similar number. But what we didn't realize was a few things that had changed in the meantime. So not only are we looking at an earlier part of the algorithm where a lot of patients will actually stop seizing spontaneously, but secondly, there was an introduction of midazolam that happened in the pre-hospital environment, and there were a lot more hospital trusts, NHS ambulance hospital trust, NHS ambulance trusts, which were using midazolam in the pre-hospital environment. So even though these children were fitting and were in convulsive status epilepticus, they were being stopped before they actually arrived in hospital. So we saw for Crescent, we saw much less number of children coming into hospital in status epilepticus than we did with Crescent. And we learned a few other things about kind of challenging research in the emergency department. We learned that we needed some equipoise. That was really important. We learned that from Eclipse, that everyone was loving or wanted to love levetiracetam a lot more than phenytoin, particularly when the RChem alerts came out saying, you know, don't do this and all this kind of stuff. We needed to be 24 hours ready. We needed to ensure that clinicians who were changing over in shifts were ready to recruit straight away. We needed to make sure that every 4 months or 5 months or 6 months, when staff changed over, that we were ensuring that those staff were trained. And so there was just a real campaign to try and kind of get everybody on the shop floor to remember these studies of the multiple studies that were happening in emergency departments. But what we found and what we learned from all the other studies that we did was that actually the input into the study design was really important. So we had to be engaged as pediatric emergency clinicians in the fundamentals of how this study was going to run in our departments. And that was really, really crucial kind of point. There was clinicians who had memory about previous studies and how they worked. And so that was really important in changing the kind of the culture for research to actually be enabled in centres. There was kind of advertising and finding your friends and having champions, all this kind of soft kind of work that needed to go on in the background in order to be able to create a vibe about it, and the orthopedic studies do that really, really well. They have great websites, and I think Dan Perry had a Christmas song generated by AI over the Christmas, you know, all of this kind of stuff, just to kind of like put it into people's minds. Lots of WhatsApp groups of, well done, such and such department has recruited, and then utilizing creative training. So not only SIVs over Zoom, but also using videos and simulation run-throughs and things like that could enable people to be more engaged in the study. And then kind of research without prior consent is it a challenge? Isn't it a challenge? I think Louise Roper in 2021 had looked at research without prior consent and had said, you know, there's kind of seven steps to do this, and to be able to do it properly is an adaptive way that people have to be comfortable with. So it's not about kind of saying, well, we'll do research without prior consent and this is the information. It's about kind of saying, okay, we've got to make sure that we establish the uncertainty and open a conversation with the patient and their families, and provide a clear explanation of how the randomization happens, and ensure that they kind of understand that actually there's no reversing this. They're already in the study. We're consenting to their data as opposed to consenting to the trial itself. For the Crescent study, about 79% of patients have consented. About 10% of patients we're still waiting on, and a very small amount of patients have actually kind of refused and said, no, thank you very much, we don't want our child's data to be included. And that was quite similar to Eclipse. I think Eclipse had 85% of patients who consented. So it shows that we can do this, and we can do this well in emergency departments, and we can do that in ways that can affect change in what we do in kind of, you know, our algorithms. I'm aware that I'm talking quite a lot, so I won't do this one, but I will do this one, and this is on my last slide. So what does the future hold for PEM and paediatric emergency research? Well, Charlotte Sloan has recently completed a revision of the top 10 priorities as part of the James Lind Alliance. So James Lind Alliance is a great priority setting partnership. And originally, 10 years ago, when we did our top 10, we just kind of sat in a room and kind of, you know, sent a few, you know, Stuart sent a few emails out and things like that. But now, as a recognized effective research network, the James Lind Alliance had kind of basically paid for it, and enabled all the organization to happen for it. So a nod to the recognition of the research network. And I mean, the top 10 priorities are similar. She's publishing a paper about it, so you'll go into a little bit more detail. But what kind of didn't come up before, which is there now, are things like mental health and overcrowding, monitoring within the emergency department, improving communication with patients and families, special educational needs and disabilities. How do we do that effectively in emergency departments? And how do we work with other services to reduce unnecessary ED attendances? So we're in a bit of a different place to where we were 10 years ago. But sepsis is still number one. We haven't, nobody's answered that question yet. And that's it. That's all I wanted to talk about. I'm sorry for slightly going over. I'm going to stop sharing my screen and hopefully answer any questions that anybody may have.
We haven't got any questions in the chat at the moment, so if anyone's got any, just pop them here, or I guess pop your camera on and just go for it.
I'm going to ask a very quick question, Shrouk, which is, how do you balance it all? How do you make time for your clinical job alongside your research priorities?
Yeah, that's a really challenging one, because you've also got to take other people on your journey with you and try and convince them that this is part of your work, this part of your job is to do this as well. So there is a conversation where you kind of have to kind of say, and you use what the GMC has said, and you use what CQC are looking for, and you use what usually the trust vision and trust goals are something related to research. You can kind of say, you know, this is what's expected of you first, and to try and show that the research on the shop floor is part and parcel of clinical pathways. So there's no separation. So a patient who comes in with bronchiolitis, the pathway for a patient who comes in with bronchiolitis is to be offered to engage in the bronch start study. So just to kind of say, look, there is no separation, it's all together now. So that's kind of on the shop floor. So it's not a separation on the shop floor. Doing it kind of writing your own protocols and reviewing HTA meetings and attending other meetings, you know, tech meetings and things like that. Some of that you can do as professional leave, some of it you can do as study leave. Some of it you try, and people want to be remunerated or acknowledged for their work. That's only fair. And if you are a co-applicant on studies, so you represent your specialty or your expertise is needed in a study, then you can get remunerated from your time. And what you find is lots of clinicians who engage in research, that's what they do. So for example, when I was part of the ECLIPSE study, I was paid a small amount of my time to be able to deliver ECLIPSE study meetings and ECLIPSE study work. That's separate to delivering the study on the shop floor. So you can kind of say, okay, well, I'm going to use this time to be able to do this, and I'm going to apply for this study, and that's going to use my time, and that I'm going to use my time to do this in this study. So that there's a way of kind of piecemeal, just collecting a little bit from other places. That's quite challenging to do. However, the NIHR have absolutely fantastic schemes. It was an absolute eye-opener for me to understand how many schemes, how many programs, how many funded programs that they do to be able to buy out clinicians' time in order for them to either learn about research or to fund them to apply for a grant or do a PhD or do an MS or something like that. And I'd encourage you all to go on the NIHR website to have a little look at what is available. So what I did as part of my research scholars post, so that was 2 years worth of being a research scholar, and that was 1 day a week. The NIHR bought my time 1 day a week. And so in that time, I was able to sit down and just have a little think about what research I wanted to do, or build the department up or something. There wasn't a particular agenda to it. It was just do something research related, because it was all about, NIHR is all about building capacity for research as well. And they've got a real drive to increasing the number of chief investigators in specialties, which is really difficult to which haven't got much research in, and they have their priorities of research as well. So mental health, I think dental, cancer, and neurology, kind of like dementia, head injury type of thing. So if you have an idea and you're going to go for it, then speak to one of the members of the NIHR, or speak to one of the kind of PERUKI people. There's so many different ways to do it. It's not just a standard contract, or it's not a something, it can be really, really flexible. And I think that really helps me as well. Sorry, that was a really long-winded answer.
That's okay.
There's lots of ways to do it.
I have got a couple of other questions that I'm hoping we'll just be able to get through. We've got probably 2 more minutes. So the first one is from Taz. And she's asking you, in the trials where you get consent first, what are the challenges from families, and how do parents feel about giving consent?
Prospective consent is getting consent before their patients enter a study, and that is really that's really challenging to do. I find it more challenging to do prospective consent in emergency departments than research without prior consent, because you have to identify the patient first, and then you have to introduce the study, and then there has to be a time where you kind of describe the study to them and then come back to them and give them the information and then come back to them again. Let's talk about it. And a lot of times in emergency departments, there's pressure on the room, there's pressure, the parents want to, and they want to go home, they've got other children to attend to, or something like that. There's maybe other priorities for that child. They might need to be admitted while the bed's ready. Come on and send them up. Oh, I'm just in the middle of a consent conversation, you know. So there's lots of pressure on time, I feel, when it's prospective consent. And that's where you need to be a bit creative. So that's where engagement of ED clinicians into research protocols right at the start, designing it, is really important. And PPI work is really, really important. Those two things combined is really important to be able to kind of say, well, we spoke to a whole load of parents and me as an ED clinician, and it would be really useful if we gave them the information, but then we did a telephone consent, you know, or we gave them the information and they were able to electronically sign the consent form after we had this conversation, or we provided them with that information, or they looked at this video because the research nurse wasn't available, or I wasn't available because I was speaking to somebody else. So they watched a video that was already, you know, kind of ethically approved. The language was correct. They watched a video, they understood the study, and then it was a 2-minute chat afterwards because all of that study information was there. So I think we have to be a bit more
good, isn't it? I mean, I've been on and looked at those videos and they're really, really simple. So they're just done in beautiful animation and really get into There's one other patient and family question, isn't there, Becky?
Yes, this one's from Dennis. When you look for input from patients and families to be involved early in the process of a research study, where are you finding them?
We have a great organisation as part of the RCPCH called Generation, I'm going to get this wrong now, Generation R YPAG group. And I'm quite lucky in Alder Hey because we've got a fantastic YPAG group, so young persons advisory group, and there are them. You can find them around the country. If you go to the RCPCH website and type in Generation R, you'll be able to find a group, and you meet with them. You meet with them online. It's kind of changed online. It used to be face to face, and you used to have to bring them donuts or something like that to kind of like, you know, to the kids, they get a nominal kind of like remuneration from for their time from the Generation R, the YPAG organisers, and you ask the questions to them, and you kind of say, yeah, you say, you know, what do you think of this study? And some, you know, a 7-year-old will say, I think that's an absolute rubbish idea. What are you doing? And an 11-year-old will say, oh, that's really, really interesting. And you've got such a range of voices there. What I do add, and similar to parents as well, they can organise a parent group as well. Charities are a really good place to look for patient and parent advocates, and the NIHR also has patient and parent advocates as well, and you can actually get a little bit of funding from the NIHR to conduct PPI work if you needed to do that.
I think so. What you're saying, Shrouk, because there's so many good ways to do it, but you've just got to get stuck in and get started. And actually, something like PERUKI is going to give you the support in order to enable to do that as well, and the confidence and the ideas behind it all.
Yeah, and it's a little bit daunting sometimes having of 10 children critiquing your idea. 10 children from primary school, you know, critiquing your idea. It's a little bit daunting, but it's absolutely necessary. The craft study has a child as a co-applicant.
That's amazing.
Yeah, and that is, I think that's where the future is. Is to kind of say we're actually listening to your voice. We're not just kind of hearing. You're actually involved in what we're doing, and you can create this as well.
Thank you. I think it's just amazing. I think it's just so inspiring to think about how we can, you know, we're asked to work with our students. We've got a lot of our students on the call tonight to improve education, but actually working with our patients, we talk about it, but we don't think about doing that with kids. And I think that is just taking things to a whole nother level. So I really hope those of you on the call, on the webinar this evening, are feeling inspired to get involved, to think about how you take your learning post the MSc. If you overseas, you know, what are the networks that are available where you are, and what can you sort of get stuck into and in there. But you can see the passion just flowing out of Shrouk, which is just fantastic. Inspirational for us
and
all.
I just have my medical degree and my postgraduate membership, and I think if I can do it, honestly, if I can do it, you all can do it. It's good stuff. Thank you so much for listening.
No, thank you so much for joining us tonight. It's been really inspiring to hear, and actually I think we need to make sure all our students going into their third year and starting their dissertations need to be listening to this as well and thinking about it, and our graduates about how do they move things forwards and take all that knowledge from, you know, they've clearly got a passion for emergency medicine, PEM, by being on these courses, and so actually how can they then take that to the next stage and be the educators of the future, the researchers, or just supporting the research to happen with their own departments, which is really challenging. Thank you, Becky and Danny, for helping to facilitate and to sort tonight as well. There's some links in the message in the chat there, which our next webinar is on the 27th of February. Slightly different topic, looking a bit more looking at a very specific bit of research, but it's 24 millimeters and 24 minutes, differences between life and death and penetrating injury. So that's going to be sort of looking more specific in that way. But if you're not part of one of our programs and you're interested in it, the links are also there to find out more about the PEM and the ERM MSc, or reach out to any of the faculty who are on the call tonight. But Shrouk, thank you so much again for coming, and we really appreciate the time you've given to us all.
Thank you all. Thank you. Have a good evening.